So, for our next one, we're going to talk about radiotherapy and the advances in radiotherapy. So I'm happy to welcome Professor Nick Slevin.
Thanks very much. I'm really delighted to have the opportunity to speak about radiotherapy, to showcase it. I think we're all agreed that prevention and early diagnosis is likely to be responsible for major changes in cancer outcomes, but nevertheless, the treatment remains absolutely crucial for those patients with established cancers. I thought this might be a good starting slide. I'm sure the audience don't indulge in idle gossip about colleagues at these sort of functions, but the theme of this meeting is very much around ideas and innovation. And Manchester obviously has a renown in terms of ideas and vision. To borrow from Tony Walsh, because I feel now like an adopted Manc, in 1948 we invented the computer, and forgive me, but in 1830 we invented the commuter by having the first timetabled intercity rail service. And for that we had to collaborate. In fact, in the rail service we had to collaborate with Liverpool, which we're still getting over. The important message here is to have implementation of innovation and ideas, you have to have team working, you have to have collaboration. Now, back in the early days of radiotherapy, Manchester was undoubtedly a leading centre for radiotherapy, and that was due to collaboration between clinicians and physics staff at the Christie. And they elaborated a methodology for dosimetry, they devised new treatments for treating cancer of the cervix, they had the first rotating linear accelerator back in the mid-1950s, and very importantly, I think they recognised that to demonstrate good clinical practice, you have to actually publish outcomes. And these are the outcomes for patients treated in the 1930s. So I think a message which all of us can learn from. Now, when I arrived at the Christie in the 1980s, I was somewhat dismayed to find that some of my senior colleagues were still riding on the coattails of past accomplishments. But I'm pleased to say that over the last 20 years, there's been a modern-day transformation of radiotherapy, and the Christie has played its full part in leading and pioneering that. And I want to just take you through some of these items just to demonstrate some of the themes. So I'm going to mention image-guided radiotherapy, stereotactic, the radiotherapy satellites that have been established, molecular radiotherapy, partial breast radiotherapy, and proton beam therapy. Now, radiotherapy nowadays is very sophisticated. We can elaborate a very sophisticated plan on the computer, but it's a real challenge still to make sure that that treatment is delivered very accurately and in a reproducible way to patients on the treatment couch every day, Monday to Friday, over several weeks. And the mechanism we use for that is called image-guided radiotherapy, where we actually integrate a CT scanner on the linear accelerator to make sure that the patient's in exactly the same position. And the first clinical use of this was at the Christie back in 2002. And this technique has now become standard worldwide over the last 15 years. But the important message here is that the Christie introduced this technology through an international consortium. CT scanning doesn't visualize very well certain cancers, particularly those in the pelvis, which are very well shown up with magnetic resonance scanning. And this is an example of a cancer in the cervix extending anteriorly into the bladder. So we saw the opportunity for perhaps integrating MR scanning with a linear accelerator, and the Manchester Evening News announced this a couple of years ago as a major breakthrough in cancer. But nevertheless, we do see the opportunity for patients who have got tumours that literally move between daily fractions, but also tumours that move during a single fraction, to use AMR scanning not only to accurately visualise the tumour, but to track its movements. Stereotactic radiotherapy can be defined by a number of characteristics, but essentially it's the use of high doses very, very accurately around the tumour, treating very, very small amounts of normal tissue to within 1 or 2 millimetres accuracy. And this approach allows us to give very high biological doses to the tumour. So that, for example, in this patient with a peripheral lung cancer, we're able to deliver twice the biological dose than we could 10 years ago. And as a result, our local control of cancer for these early cancers is extremely high. Stereotactic radiotherapy can be used in other parts of the body. So, for example, this patient has a very large cancer in the liver, which has responded well to radiotherapy, which then has allowed the surgeons to resect the right side of the liver, and the patient remains well 2 years post-treatment. Now, I think we all recognise the perennial clash between local services, local access for patients, versus centralisation, increase in patient throughput, engendering expertise. With the establishment of the 2 radiotherapy satellites in Oldham and then in Salford from 2010, we believe the patients had access to the best of both worlds. They had access to patient specialists, to Christie specialists, who would actually devise the treatment management. The treatment plan would then be elaborated on the Withington site, and the treatment plan was sent down the wire electronically to the treatment satellites, which delivered the treatment locally for patients Monday to Friday over several weeks. Now, this electronic connectivity, or digital architecture as I've called it, would not have been possible without very good collaboration with colleagues in both Oldham and Salford. And the future really is collaboration, I believe, through digital connectivity. There are a couple of other examples I want to give. We can also deliver treatments very accurately using molecular radiotherapy and interventional radiology. So this is an example of using radioactive yttrium to treat tumours in the liver. And this is another example where we actually treat the site of a previous breast cancer, which is marked by clips. And we treat not the whole breast, but just parts of the breast in terms of the area of greatest risk of recurrence. Now, these innovations cannot be implemented without the collaboration of colleagues across Greater Manchester. Now, I hope you're all aware that just over 100 years ago, the Proton was discovered here in Manchester by Ernest Rutherford and his team. So it seems fitting that Manchester will host the first NHS Proton beam service, which will start clinical work in August 2018. So this is being done as a national service hosted by 2 centres, the Christie and University College London Hospital. So single service on 2 sites. And I don't want anybody going home to supper tonight, or should I call it tea, and the family saying, have you learned anything today, without mentioning the Bragg Peak. And the Bragg Peak is the physical characteristic of particle beam therapy, where the beam actually stops near the end of its range, deposits its ionizing energy, and then there's no exit dose. This is fundamentally different to traditional X-ray treatment. So, for example, the illustration on the left here shows a child who's having the brain spinal cord treated with radiotherapy, where no radiation goes anteriorly into the heart, the lungs, the ovaries, etc. Whereas with traditional radiotherapy, these normal organs get unwanted radiation. How can we actually demonstrate that there's no exit dose? Well, this is an MR scanner showing that just anterior to the spinal cord, the radiation has actually stopped. This is another example of a child with a brain tumour where the amount of normal tissue being treated is minimised by using proton beam therapy compared to normal radiotherapy. And as a result, there are improvements in terms of IQ, growth, hearing, eyesight, and the production of second cancers. So a lot of proton beam therapy relates to reduction in long-term side effects. We're very excited to be hosting this service next year. We will have a particle accelerator generating protons for 3 treatment rooms and research in a 4th room. The technology is large, but also the therapeutic potential for this modality of treatment is also large. And it's not only a reduction in the side effects, but this is a tumour which is difficult to treat in the base of skull. By minimising the amount of normal tissue we're treating, we can actually increase tumour control and cure rate. So you can see here the amount of radiation given is very much related to the cure rate. So by giving high radiation doses, we get high cure rates. This complex service is only possible again with collaboration with colleagues in the Manchester Children's Hospital and Salford Royal Neurosurgery in particular. So again, it comes down to the implementation of new techniques through collaboration and team working. So I've tried to run through very quickly the developments over the last 20 to 25 years: intensity modulated radiotherapy, image guided radiotherapy, volumetric arc therapy, MR-Linac, and proton beam therapy. Does that actually produce improvements in patient outcome? Let's just take lung cancer as an example. For early lung cancer, we've been able to demonstrate that almost 100% local control and no serious side effects with stereotactic radiotherapy. For patients with more advanced cancer, the standard of care is intensity modulated radiotherapy. We've been able to demonstrate from looking at 9,000 patients that the average survival has improved by 20 to 25%. So finally, I'm leaving you with the thought that there is a difference between knowledge and wisdom. We've been able to implement these new technologies, these state-of-the-art treatments for our patients across Greater Manchester by collaborating with colleagues across Manchester, as well as nationally and internationally. Thank you very much.